Welcome to Module 4 of American Hospital Association's Conversation on Social Determinants of Health. In today's module, we're going to focus on housing instability. My name is Dr. Rishi Manchanda. I'm the founder and president of HealthBegins, and I'll be joined later today in this module by Dr. David Perlstein, who is the president and CEO of M.P.H Health System in the Bronx. In this module, we're going to focus on a few things. First, we'll look at the why. What is housing instability, and what is its impact on health? We'll then speak to the how. Different approaches to address housing instability, including the use of upstream quality improvement. And finally, we're going to bring this all home, so to speak, by bringing in Dr. David Perlstein from M.P.H Health System. And Dr. Perlstein will share some of the work that he and his colleagues have done in the Bronx and his community to not only develop ways to connect patients with housing needs to appropriate resources, but also the steps they've taken as playing the role of an anchor institution to address housing instability in a pretty novel way. So with that, let's get started with the why. To illustrate why housing instability and housing in general is linked to health and healthcare, I wanted to tell you a story of a patient I cared for while working in a clinic in South Central Los Angeles. I'll tell you the story of a patient I named Veronica. That's not her real name, but we'll talk about Veronica, and you might find this familiar in your own setting. Veronica is a middle-aged woman who unfortunately had been suffering with a chronic headache for a number of years. She was bouncing in and out of local hospitals, emergency departments, and primary care clinics, always trying to seek relief for her chronic headaches. Every time she'd encounter a clinician, either in a hospital or in primary care, she'd have a basic workup, be prescribed some pain medications or some other medications for some associated symptoms, and get sent home. Her symptoms would improve modestly, but invariably within a short amount of time, her symptoms would come back. When Veronica came into our clinic, she had actually been to 3 different emergency departments in the 3 weeks before I met her. And in each time, she came up short. Her symptoms improved temporarily with some of the pain medications she received for her headache, but the symptoms came back. So she was pretty exasperated, as you can imagine. When we saw her in our clinic, we started thinking about what could have contributed to Veronica's visits to the emergency department. What could have, more importantly, contributed to Veronica's symptoms, to her headache. And what we found out was by screening for housing instability and for housing insecurity, including screening for the presence of any substandard housing conditions in particular, we found out that Veronica was suffering from chronic migraine headaches and had associated sinus congestion, and that the constellation of those symptoms was itself linked to poor housing conditions. In particular, we found out by screening that Veronica had water leaks, mold, as well as cockroaches in her home. And that led to the frequency of visits to local emergency departments and hospitals in general. It was the ability of our team to assess and also working with partners in the community to address those issues with her housing that was really paramount to getting her improved outcomes. So Veronica's story is just one story of many that illustrate the link between housing and specifically housing instability to health and to healthcare. We know that housing instability in general takes on many different forms, as you can see here. Let's go a little deeper into defining housing insecurity, which is one facet of housing and the way it plays out in health. Housing insecurity is defined as difficulty paying rent. It's a situation specifically where more than 30% of household income is spent on housing. There are some symptoms that reflect housing insecure households. Those who have frequent moves, those who live in overcrowded conditions, or those who report doubling up with friends and relatives who couch surf. Those experiences are really symptoms or signs of someone who's living in a housing insecure environment. We know that the most extreme presentation of housing instability or housing insecurity is homelessness. Now, there are a number of different definitions out there that we wanted to share a few of them with you. Because it's relevant to a lot of the emerging initiatives at a community level and even nationally to address homelessness. So the first definition of chronic homelessness comes from the Department of Health and Human Services. According to HHS, chronic homelessness is defined as an unaccompanied homeless individual with a disabling condition who has either been continuously homeless for a year or has had at least 4 episodes of homelessness in the past 3 years. There's also a definition from the Public Health Service Act, which defines homelessness as a homeless person who is an individual without permanent housing who may live on the streets, stay in the shelter, mission, single room occupancy, abandoned building or vehicle, or in any other unstable or non-permanent situation. The important thing we want to stress here is that homelessness itself obviously is a severe manifestation of housing instability, and that it can be defined differently by federal and even state regulators and agencies. And it's important as a hospital executive, and a physician executive in particular, to understand that there's different definitions out there, because those definitions can often be important as you partner up with local stakeholders who are engaged in broad scale and community initiatives to decrease, if not prevent, homelessness. The question at large is whether it's homelessness specifically or at large housing instability, how does this impact health? This table gives a quick snapshot of the multiple health conditions that are related to these different types of housing instability issues. So you can see here examples of how homelessness, specifically lack of shelter or residence in transitional, even emergency shelters, can be linked to a variety of health conditions, such as increased rates of chronic and infectious conditions, COPD issues. It can be related to or exacerbate mental health issues, including depression, and it can also lead to developmental delays in children. Let's also look at lack of affordable housing, again, which is represented by those who experience a severe rent burden or experience overcrowding. We know that lack of affordable housing is also related to health conditions such as stress and depression and anxiety, related to poor self-reported health, and also delayed or even diminished access to medications or medical care. And finally, and this is apropos of the story of Veronica that I shared, we know that poor housing conditions manifest through issues like exposure to allergens like mold or asbestos or pests, as well as structural issues like leaks or problems with insulation or heating. That poor housing conditions also are related to specific health conditions. These include asthma or other respiratory issues, including the ones I mentioned with Veronica, allergies, as well as some significant ones that we've also been tracking with both in the medical literature as well as in the news in general, issues like lead poisoning and even mechanical falls and other injuries. So housing instability, and the many forms of housing instability clearly have an impact on health. They clearly have an impact on health care as well. So now that we've reviewed that literature and understood that impact a bit better, let's talk about what we can do about it. How do we actually address housing instability? In previous modules, we've discussed upstream quality improvement, which is this intersection of quality improvement science and experience with upstream issues and upstream factors. When we think about upstream quality improvement, let's go back to the basics. Let's, again, think about the fundamental three questions of quality improvement. In particular, let's focus in on this third question of what changes can you make that will lead to an improvement in the first place? I'm going to focus on that for a moment because most efforts that we're seeing in hospitals across the country as it relates to housing instability have to do with screening. Screening, it's believed that screening as a change can lead to improvements by screening those who are housing insecure and identifying those needs. The theory is, of course, that we can then hopefully connect people to resources. So screening is an important change that we're all looking at in America's hospitals. Now, there are a variety of different tools that are being promoted and recommended to screen. We'll share here with you one tool recently endorsed by CMS. This is a tool specifically as part of the Accountable Health Communities model. They proposed using two questions for screening for housing instability. The first question is about living situation, and this question gets to the stability of the living situation itself, while the second question gets more to the safety of the living situation. The second question looks at issues like exposure to pests or lead paint or lack of heat, etc., to understand whether someone's living in a safe and healthy environment. These screening questions and questions like them are increasingly being adopted by healthcare organizations as part of their own upstream work to address housing instability. Now, the other question as part of quality improvement, of course, is the fundamental one, which is what are we trying to accomplish? And we know that as more and more hospitals think about what they're trying to accomplish vis-a-vis housing instability, that many are thinking about how to better screen for and refer people with housing needs to appropriate resources in the community. And we're seeing a great number of really important partnerships forming between hospitals and community organizations to address those unmet social needs. Again, social needs and specifically housing needs for individual patients. We think that when it comes to addressing social determinants, including housing instability, it's really possible to think big when setting aims. What else could we be doing beyond, including, but beyond screening for individual housing and security needs? And there's really no one better to speak to this idea of thinking big when it comes to addressing housing instability than Dr. David Perlstein. Dr. David Perlstein is the president and CEO of S.P.H. Health System in the Bronx in New York. And David, again, it's a privilege to have you join us today. The floor is yours.
Thank you, Rishi. I appreciate the opportunity. Let me tell you a little bit about our hospital. So St. Barnabas has been around for about 150 years. It was originally founded 1 year after the end of the Civil War. It was in the Bronx at the time, and it was called the Home for the Incurables. It was a chronic care facility that took care of patients who otherwise really had very little chance of being cured, a lot of TB patients, et cetera. Obviously, the community that we served changed a number of times, and as a result, because the hospital's mission always included serving the community, the hospital had to change. In the 1800s and the 1900s, the hospital was very dependent upon philanthropists such as the Vanderbilts and the Astors and the Roosevelts. And currently, we do not have Vanderbilts and Astors and Roosevelts taking care of our needs. And as many of you know, a lot of hospitals do depend on a tremendous amount of philanthropy to get their programs taken care of. And we, because we are located in the Bronx, in a very poor neighborhood and a poor community, we suffer from what's often called philanthropic disparity. We receive very little in the form of donations, which has resulted in part to negative margins that limit our capital expenditures. So what we are today is we changed our name to S.P.H. Health System a few years ago to really reflect the fact that we're not just a hospital. And we are a community hospital and a not-for-profit, non-denominational community hospital. And part of our wish to really go all in on the idea of population health was to change our name to S.P.H. Health System, which is more of a reflection of the fact that most of our visits are not in the hospital, but they're outside of the hospital in our ambulatory care sites, in our behavioral health sites, in our substance abuse sites, at our private programs, and our ED. We've been in the same spot since 1874, and it is a community that is one of the poorest communities in the United States, with the average per capita income for a family of four from anywhere from $12,000 to $13,000 a year. Our challenge is that our patients really are covered, 95% are covered by a government payer. And 80% of those are actually Medicaid, which of course leads us to a real challenge when it comes to trying to get a margin to help us with our mission. For those of you who are not really aware of the Bronx demographics really reflect U.S. immigration patterns as a whole. We are constantly evolving because our patients are constantly evolving. So basically, again, the challenge that we have is trying to take care of a very heterogeneous community whose one constant issue they have is their poverty. Medicaid in New York State has been constantly on the move. There was an expansion of the Medicaid system back in the 1990s, which allowed for and required all pediatric populations to be covered by managed care, by Medicaid managed care. That's when this hospital was actually put in a position to get the funding and the financing to be able to support a building of a pediatric program. It also enabled hospitals such as ours and providers to really move towards patient-centered and community-based population health models. And at the same time, it allowed us to start thinking about developing our own managed care program because we had a loyal patient population. And as long as we were going to have that loyal patient population, it made a lot of sense to be at risk for those patients who were using the system and continue to use the system. In addition, New York State in 2015 got a waiver to change the way Medicaid beneficiaries were taken care of, and that was through the DSRIP program, which is the Delivery System Reform Incentive Payment Program. And the idea was that you were supposed to accelerate the integration of social determinants of health into the care delivery for Medicaid beneficiaries, but also change how Medicaid beneficiaries were being cared for from a volume-driven system into a value-driven system. So DSRIP allowed us to think bigger. It also allowed us to get the funding to think bigger. So as I mentioned, in 1998, we started a program called Partners in Health. This was St. Barnabas Hospital's first foray into managed care. It was a Medicaid-only plan. We had about 30,000 members. We actually did make money on that because of the way we managed our patients. But we realized after a while that there was no way we were going to be able to grow, and because we didn't have a Medicare license, it made more sense for us to join a larger program, and we ended up becoming a member of the Health First plan, which is a provider-sponsored health plan, and then we did that in 2007. So what we ended up doing is shutting down the Partners in Health program, and we moved those patients into Health First. Health First is one of the largest Medicaid providers, managed care providers in New York State. It's a not-for-profit hospital-sponsored and governed health plan. I'm on actually the executive committee on the board of that managed care program. We have full capitation risk for our members assigned to S.P.H. We do make money on that business, again, because we're allowed to manage our patients, and our reimbursement is also dependent on our quality, and we have been either the number one or number two in terms of quality for the last several years. We also, at the same time, instituted a number of patient-centered practices, including patient-centered medical home implementation. We minimized unnecessary inpatient admissions, lowered length of stay. We decreased our hospital-acquired conditions, and we improved case management and all those things. And we thought at that point we're ready to dive into the social determinants of health further. And we did all these things before DSRIP came around. And DSRIP, again, as I mentioned, gave us the funding to be able to address SDOH needs, or social determinants of health needs for our patient population, which included if we have an asthmatic that shows up multiple times in the summer months, we could actually write a prescription for air conditioning in order to keep that patient from having asthma attacks at night. That's something that you couldn't do with the Medicaid program in the past. So these are things that we've absolutely taken advantage of, but it's also given us the ability to even think bigger, because it was a significant funding that occurred as a result of DSRIP, which also involved creating really large partnerships, comprehensive partnerships with community-based organizations, federally qualified health centers. We also are partnering with Montefiore Health Center, Montefiore Health System as well. And again, the idea is that we're finally all working together in a patient-centered way to address all the challenges of being a community member in the Bronx. That led us to really thinking, okay, well, how can we address SDOH best? And the fact is that often it starts with housing. Years ago, in my role as ambulatory pediatric director, I ran a survey to try to look into why it was always so difficult to reach out to our patients after they came to visit. And as a result of that survey, we went through and we asked patients every single time. We had the physicians actually ask when the patients came in to see the providers. We asked what their addresses were and whether they had changed. And I found out that close to 40% of my patients within a 3-month period changed addresses, which tells you just how challenging it is to have any kind of continuity, to be able to communicate with patients routinely, and also the challenges that patients must have in terms of of housing insecurity. So we were sitting on a large parcel of land that originally was being reserved to build a new hospital. It served as a parking lot for a while, and it's right across the street from us, and it's next to a current ambulatory care center that we have. And we thought, all right, well, now that there's an opportunity for us to think bigger, what value will this land bring in a world of population health where maybe hospitalization is not the answer and is not the future? So we looked around for partners to see what it is that we could actually do with this space, and we met with a bunch of folks, and it took us a while to do it. Our goal being, again, would be to really talk about building out affordable housing for our community, since we know and we knew that a lot of our patients suffer from housing insecurity. And we thought, well, as long as we're doing that, then we could also, in exchange, make sure that we build a state-of-the-art, ambulatory care wellness center. And we found the right partner who was even willing to limit who would be able to rent out the storefronts in the buildings. And again, that's often where realtors make their money and developers make their money is on the leases of commercial businesses. But we were able to find a partner who was committed to limiting storefronts to wellness-related things, so no liquor stores, no stores that sold cigarettes. We convinced them that the benefit of having a daycare provider in the building would be great. And we now have this 156 million mixed-use development that is almost completed. The housing component is almost completed. It involves two different units, a south unit and a north unit. It also included 95 units that are being held for formerly homeless families and for high utilizers of the Medicaid system, which addressed, again, the housing insecurity. All in all, we basically partnered to have this developer build out 314 units of low-income housing apartments. And then 50% of those were actually reserved for those individuals already living in the community. It took a tremendous amount of work and partnerships with the community, with our local politicians, with obviously the developer, with the banks, with HUD, with anybody else that was willing to listen. But in exchange for the land, we actually negotiated this 50,000 square foot of space that's going to be used as a wellness center. It'll be focusing on both primary and acute care, also non-traditional preventive programs such as a women's and children's center, and urgent care to decant our emergency department, a gym, integrative health center, teaching kitchens, in order to train our staff and also the community how to prepare healthier foods, a rooftop vegetable garden, which we will be selling and giving away any of the produce, but we'll also be using it as educational opportunities for school children and also our patients and their families. There's a lot of green space that's going to be involved in these, and a large community meeting space. We did get funding from New York State as part of the transformation program that they have in place for $22.6 million, which allows us to actually build this out. We expect families that will be moving into these apartment buildings by the end of this year. We will take control of our space and start to build out our space in 2019 with a goal of opening up either at the end of 19 or in early 20. We're looking to improve both the qualitative and quantitative measures of wellness. We're looking for decreased hospital admissions and fewer unnecessary ED visits. That's a big ask, but that's part of the district requirements. We're looking to improve the overall health and wellness of the Bronx community, but also our real goal is to get to a point where we don't have to push wellness on our community, but we engaged our patients and our community members to really create partnerships that will result in sustained and continued improvement in their wellness. So our challenges in doing all this, besides the financial challenges and the commitment challenges, are really the challenges of making sure that we are addressing the changing needs of a changing demographic. We have, again, as I mentioned, a very ethnically diverse and changing group who are not always aligned with one another. But again, the one homogeneous factor is that these are all poor people struggling to really, do good things for their children, to create lives for themselves. And we believe as healthcare providers and as an anchor institution that it's our responsibility to help them get there. Another big challenge is we are all in on the social determinants of health game. We're all in on population health. And we made some changes, as I mentioned, before DSRIP came around, which resulted in our being more patient-centered, in I believe, saving a tremendous amount of money for the payers and for the health systems by decreasing the number of patients that we are admitting through the emergency department, by using guidelines and following guidelines, and by improving our case management. We went from about 30% of our ED volume was getting admitted down to about 12% being admitted. Now, for those who understand healthcare and hospitals, even though we are all in on the idea that value is the future, we're still getting paid on a volume basis. So it really just killed us in terms of revenue losses and a fee-for-service. And if we had time back, we probably would have made a deal with the state or the payers to basically cover those losses up front. A number of lessons that we learned from this. The project could never have gotten off the ground without the right partners, and you really have to have a broad partnership. So again, as I mentioned, we found the right developer who was socially conscious, that was mission driven. We found economic partners, bankers. We found community members that thought this was a great idea. City and state government and elected officials. We're very excited about the idea that we were going to use this place to build out permanent housing, safe housing for low-income individuals who are already in the community, because, again, one of our goals was not to gentrify the neighborhood through an external source, but to create opportunities for our community members by offering them safe housing and permanent housing. We couldn't have got off the ground without really engagement of our board of trustees or by my predecessor, a guy by the name of Scott Cooper, who was a pulmonologist and worked in this community for 30 years. We also had to surround the project with the right people, not only to buy into the work, but also to sell it. So our financial leadership has been engaged in this. Certainly our clinical leadership has been engaged in this. And I think it's important that you always think in terms of that right culture to make sure that you can actually deliver on your promises. One of the things I think we could have done better, you got to bring community members into the discussion early on, who can speak to the true needs and challenges. And I think that one of our issues is, as healthcare providers and as well-educated individuals, sometimes we assume we know better than the community. And I'm not saying that we're doing anything wrong, but I think that to address that potential pitfall is really very important. And I wish early on we had a community member on our committees that were putting together the plans for these programs. It's not too late for us because we are still in we haven't started building anything out yet. So we are in the midst of another needs assessment, a community needs assessments, to make sure that we're doing the right thing. So that's a long-winded description of the project and of St. Barnabas Hospital. And I'll turn it back over to you, Richie.
David, thank you so much. There's clearly an incredible story here, and I will call out the fact that in listening to you tell the story, it's clear that history plays a big role. I think there's also something that I heard in your story that I want to reflect back to you, and I think might be relevant for folks listening in. You mentioned early on you started in your pediatric practice when you were, I think, you were the director of the ambulatory practice. You started a process to start screening patients for unmet social needs, and how that was an aha moment. I think the 40% stat is something you shared out of that project. Now, a lot of hospitals, as you know, are engaging in screening, right? A lot of them are now, more so than ever before, now starting to screen for issues like housing insecurity and food insecurity, transportation barriers. And I wonder if you reflect back on your journey, knowing that screening was one of the initial instigators of your aha moment, if you think that folks who are now engaged in screening across the country in America's hospitals are ready to recognize the aha moments that might be there. In other words, are we applying perhaps too technocratic of a lens as we think about implementing screening projects? Are we in the mind space to be able to recognize the aha moments as you did when you started screening many years ago?
Yeah, I think this is a huge challenge, Rishi. I think what the real problem is that we're really good at collecting data, and often we're not so good at actually implementing transformation, which addresses the causes of the challenges. And so even when we started this program, we started screening for housing insecurity in a sense. We didn't really have anything to do to change it. It became much more of we really have to start addressing this and looking at it and seeing whether we can accommodate patients who have to make these trips. But we had no system in place initially to actually address housing insecurity. And in fact, when we started this, it wasn't even our role. It really wasn't being handled across, at least in the Bronx or in any other community I know of. And so we didn't really have the tools to address the needs, except by putting together a list of referral sources. And I think that we have gone way past that, and most institutions have to go way past that to recognize that health, wellness, and health go far beyond just getting vaccinated. And I think it's incumbent upon all of us to recognize that. And I'm pleased to say that there is finally funding in a lot of places that are helping us to address these shortfalls, but not everywhere. And I think that I am pleased to see that around the country people are starting to screen for SDOH issues. But a lot of people aren't addressing the specifics of it yet, and I think you got to start somewhere. And my feeling is, if you're someone in an organization that isn't all into this yet, I think you have to educate yourself about what opportunities are out there, and you have to find partners within your community that are already doing this. A failure of hospitals in the past has been that hospital leadership has always felt that because they're bigger and badder, they can do it better than everybody else. And one of the changes that had to occur within our organization, we were no different. Multiple times we would see a community-based organization doing something great, and we would pretend to be a partner with that organization, but instead we would actually just build a better program, in quotations, that would be able to address the same issues that they were addressing. And through the delivery system reform, it enabled us to actually create partnerships and actually fund those community-based organizations that were already doing this great work. And it allowed us not to have to spend energy on duplicating what was already a functional answer to some of the system. So I think you gotta, as a future physician leader, a future physician executive, or anybody working within a leadership of any kind of program or community, you have to get outside your walls. You have to see what's out there. You have to meet with community members. You have to meet with community-based organization, with directors of those programs, because you'll be amazed to see what kind of work is being done in your communities already.
Yeah, and David, is that point that I wanted to come at from a perhaps an unexpected kind of angle right now, because there's something about what you just said right now that reminds me of something in your story that I think will resonate with a lot of folks, and that is what happened when you talked about the health first work, when you, as a system, took part in a capitated model, a value-based kind of payment model, if you will, and then achieved in the last few years one of the top one or two kind of positions in terms of quality performance. And so clearly, quality improvement within that contract, that capitated contract, was part of the reason you guys were recognized. The reason I'm bringing that story up in reference to what you just said is this. Certainly one of the things that I found most compelling of quality improvement methodologies is the get out of the building, the Gemba walk, right? The ability to go find out where people are at. And what you just spoke about in the context of social determinants of health sounds really similar to what we already know is a best practice in good old-fashioned quality improvement and performance improvement work. Am I building a bridge that doesn't exist right now between what we know in terms of quality improvement successes and what we need to do for social determinants, or does that ring true for you?
Well, personally, it rings true for me. And in fact, I will tell you that the reason I'm in this position today is because of my commitment to quality improvement work. So again, I guess it's that pediatrics thing in me, but I got very involved with the IHI pretty early on and implemented a lot of programs within the hospital that actually started to follow both the PDSA cycle and looking at the model for improvement, but using kind of the same quality practice to try to solve problems. And I think under the idea of looking outside for help or looking outside for answers, obviously it totally aligns itself with the idea of the quality improvement science. So it's not a far push. And in fact, again, just bringing people back to what we are, it took a lot of reculturing to get where we are. This doesn't happen overnight. This institution really was quite fantastic at billing Medicaid, and we used to be one of the most profitable organizations in the Bronx, certainly, and in the city, from the standpoint of all of the contracts that we had and our amazing ability to automatically bill for threshold visits. I don't think that we were delivering high quality care at the time. And when I stepped in 99, it was kind of the coming to the end of that approach. So it also positioned me in a way to start looking at what I believed were really systemic failures of our system. Mm-hmm. But since then, we really have spent a lot of time moving towards becoming a highly reliable organization. We certainly have adopted the quadruple aim. We have lean daily management rounds. We have safety calls. We're doing all those things that are necessary. And in fact, it pays off in both, I think, staff satisfaction, but also in patient safety. Mm-hmm. Because we celebrate the wins and celebrate the challenges. Mm-hmm. So I think that it's all related.
What I'm hearing is, especially that last comment there, it's all related, is that this culture of continuous improvement that clearly you have adopted within S.P.H. And that I think a lot of hospitals have adopted in varying degrees across the country right now, that culture of continuous improvement is in some ways very aligned or an opportune kind of touchstone for being able to move upstream to address these social determinants of health. That continuous improvement and addressing social determinants of health may be actually cultures that we can kind of bring together as we think about hospitals. Well, David, that point is a wonderful point to kind of end on. Clearly, in the story of S.P.H. right now, especially with this Third Avenue Development Project, this great example of how to address housing insecurity, especially as not just a service provider, but as an anchor institution in the Bronx. I think what you're reflecting is what it looks like to actually engage in a paradigm change. As you said, the paradigm change is not something that comes easy, right? It does require folks to look inward and make decisions about what type of model, what vision of care they want to buy into, and then, of course, how they can kind of be part of a team to help implement it, help sell it. And so this story is incredibly rich. I really want to thank you for this time and sharing your story today. Looking forward to future conversations both with you and other AHA leaders across the country as they follow your lead and join with you in terms of moving upstream, especially when it comes to addressing housing insecurity. So David, thank you for your...
Thank you, Rishi. It's been my pleasure.
That brings us to the end of today's module, Module 4 on housing insecurity. I want to thank Dr. David Perlstein for joining us today, and thank all of you for joining us as well. We hope that through today's module, you've both improved your understanding of housing insecurity and its relationship and impact on healthcare and health outcomes. Got a better understanding of how you can use tools of leadership, including quality improvement, to be able to drive upstream changes to address housing insecurity in your own hospitals and community settings. And lastly, through the presentation of our case study site today, Dr. David Perlstein and his work at S.P.H. Health System, we hope you gained a better understanding of what this can look like in practice. We look forward to helping and observing all of you as you proceed upstream on your journey to improve social determinants of health and health in general in your communities, including your ability to improve housing insecurity. We wish you well. Thank you so much for joining.